Our role in this panel is to talk a little bit about some of the activities that are happening at Rutgers in terms of child health, and particularly the areas that we're interested in of nutrition, family and child nutrition, physical activity, healthy weight, and how these areas and the individuals who do the work relate to some of the work that we've heard this morning. And specifically, what can Rutgers bring to the table, both in terms of scientific study of these areas and in terms of interaction with the community, interventions, which we've heard should not be from the top down, that's for sure, but participatory research with the community engagement. So we'll start out with everyone on the panel. We'll talk a few minutes about what they do, how they come at the questions that we're interested in here at this conference in terms of child health in the 21st century. And then we'll have a few sort of panel discussion questions, and after everyone sort of introduces themselves, feel free to ask questions as well. So, Dr. Potter.
Hi, everyone. I'm Jonathan.
Let's get you a microphone.
Okay. Probably loud enough, but hi, can you hear me okay? Not too loud. I'm Jonathan Potter. I'm Dean of the School of Communication and Information. I'm not from around here, as you can probably tell, but I feel like I'm a proper New Jersey person now. I was trying in the course of the afternoon, some wonderful papers this afternoon, to think of how to characterize the relevant research of the school in the way that's most useful. And I've chosen to do it like this in 4 themes. First of all, if one thinks of each of these themes involving children, so children in primary care settings, and here we're thinking about information delivery, about diagnosis, about participation in various kinds of health programs, advice delivery, advice compliance, and the various kind of emotional elements that go along with that. And our researchers in the area of communication, media, and information science all have different takes on what goes on here, which comes together. It's a very interdisciplinary unit. Then if you think about children in families, we have people who are interested in food assessments, for example, and eating practices, offers, requests, directives, threats, admonishments. I myself spend a chunk of time looking at parents telling children off for not eating the healthier foods on their plates. I've been part of a big team research which is looking at the handover of food items and the precise positioning of thanks in those handover sequences. And I'm a strong believer that this concrete specifics of behavior is the place at which a lot of the business, the cultural, communicative, psychological, sociological business becomes live. We have groups of people looking at children and adolescents in media environments, the role of advertising, sugar and diet, the different platforms that children use to get their information, the different sorts of new possible technology that they could draw upon and how that operates. To take one example, Amy Jordan, who came to us from Manenberg, worked with the city council there on their sugar tax and designed with advertising companies sets of adverts about healthy drinks and the amount of sugar in drinking. And a 4th theme, I'd say, was be children and communities, the way in which different organizational setups provide for how children understand things, health communication in communities, digital inequality in communities, issues to do with alcohol and drug use, and so on. I see important, I loved the talks earlier on, both Liz's and Chris, I thought had a lot to offer us. I see one of the issues for us in New Jersey is thinking about embedding issues to do with health and eating in broader sorts of practices in relation to how social work, how policing, how community organization and local democracy, how news and local news delivery can be achieved, putting those things together at a community level where it speaks to individual families and to the communities in that level has the prospect for improving change, and we have a number of people working at those kinds of levels. If we can bring the health and the eating piece into that, I think that will be a really important development.
Thank you very much.
Hi, I'm Michael Yedidia. To place my work on childhood obesity, which is, I think, why I'm here today, in context, when I started my training, I was in public health, and I really aspired to do some of the things that the people in the earlier panel on community work do, namely to have an impact on the health of the community as well as the health of individuals. I then trained in sociology to attempt to do research that would inform such interventions, and that's where I spent most of my decades of work. I've gravitated toward childhood obesity fairly recently, about 10 years ago. So I have that humility that was mentioned early on to being somewhat of a newcomer. I didn't start out as either a nutrition researcher or a community interventionist. But if you look at if you were to see our team, there isn't another sociologist. We have nutritionists and geographers and economists, and I mean, this work obviously compels interdisciplinary work. So that I have these two, I and this large team are doing two longitudinal cohort studies focused on children in New Jersey. The aim was to collect data and look at issues that are relevant and make those data relevant to progress and change in New Jersey while addressing issues of national import and therefore generating NIH funding. There's a tension between that, and I won't go on and on about that, but on one hand, to convince NIH study sections that research done locally, exclusively locally, on local data is relevant to national scenes. And then there's the tension of the constraints of, or the timeliness of findings for community organizations is a problem, and it's not a problem that we have solved at all. There's a tension between doing the work in the longitudinal study, and we'll have some findings in several years, and generating and making the data available. We have been doing that. This started out as actually a cross-sectional study, not a cohort study, to inform community interventions in Trenton, Newark, Camden, and New Brunswick. And those are our 4 cities that we've stuck with. We collected enough data on the food and physical activity environment, all geocoded so that we have every child in our household panel has a value that expresses their proximity to a change in the environment. And that change can be big things like a supermarket moves in or a new playground, but more importantly and more difficult to document are the kinds of, we call them upgrades, that are largely the focus of interventions among many of my colleagues who are here this morning, as well as the IOM best practices. It's getting healthier food into corner stores. It's adding some playing fields to existing playgrounds. It's making parks more safe. It's safe routes to school. That doesn't mean that every curb cut might affect a child's weight status, but we do collect those data, and then we aggregate that to look at the influence of those factors. We do have ongoing rates of BMI for those 4 cities, and we're about to release a new round on our website next week. Again, it's Trenton, Newark, New Brunswick, and Camden. And we have a second project, which I won't go into great detail about because I just want to illustrate what we have and what we're doing and what I see later as the implications for further work. The other project focuses on schools as the unit of analysis and follows 120 schools over a longer time period. But I want to talk about an intervention research project that we have proposed, so it's not funded yet, because I think it exemplifies maybe something that's more forward-looking, that is an intervention that would not be expensive to implement and would, I think, have national viability, but we're going to do it here in New Jersey and in Arizona, where one of my collaborators, Poonam or Ivachaspati, who some of you know. This takes a Department of Agriculture program called the Fresh Fruits and Vegetables Program. How many of you know about this? Yes, okay. Well, just briefly, I can't do it justice, but these are programs that elementary schools participate in. They introduce new fresh fruits and vegetables. There's a whole menu of items that they had introduced. I don't know if they have the elan that Chef Ian had, when he was introducing the, but who knows? It remains to be seen. It's thoroughgoing. There's a lot of anecdotal data out there that says that it does increase consumption. We're not going to limit our controlled study, I won't go into the design, just to whether it does that, although we will nail that down with a new biomarker of fruit and vegetable consumption, namely the skin carotenoids for those people who are further closer to the cellular level of the socioecological model than we are. We're going to overlay that. First of all, we're going to look, because we have anecdotal evidence through talking to people here in New Jersey, and also Poonam did some work in Arizona, more systematic, which would be preliminary studies for an NIH proposal, namely that kids who participate in these programs not only tend to want to eat more of those fruits and vegetables, but they nudge their parents to get more, to eat more. Why isn't our family eating more? So we're also going to look at the spillover effect. We're going to look in a controlled design, lots of arms controlled, to see whether indeed it increases the consumption by their families and their siblings. And then here's sort of the more forward-looking aspect, I think, because you could say, I think a lot of the people in this room would say, we know that already, maybe it wasn't published in pediatrics or something, and maybe it would help get more funding to it if it were, but we know that. But what we've done further is we've presented data to grocers associations, particularly Poonam, who was in Washington last year, and they got interested in the idea that we kind of seeded among them of cross-promoting some of those fruits and vegetables, or all of them, featured in the fruits and vegetables program. So we've got commitments from major grocery store outlets here and in Arizona to work in partnership with the fruit and vegetable program school, as well as schools that don't have the fruit and vegetable program, to cross-promote, and we will look also to see whether that cross-promotion further enhances the consumption, as well as we'll look at cash register receipts, because that's kind of important to the stores. Now, this is not going to be something, this is not an intervention. This is a research intervention, so you're not going to see hundreds of these going on. These are like, matched sets of schools and stores. But we think that, and assuming we can turn this around quick enough, that it can have value to communities in trying to enlist cross-sector collaborations, which a lot of people are trying to do, including the commercial sector. So that's some of what we've done.
Good afternoon. My name is Sherry Soriano, and I'm the department chair for the Department of Family and Community Health Sciences, and also known as FCHS. And our department is a part of Rutgers Cooperative Extension. For those of you who may not know what cooperative extension is, every state has a land-grant university, and Rutgers is the land-grant university here in New Jersey. What we do is we provide community outreach throughout the state in the counties. So our department provides community outreach on nutrition, physical activity, and generally healthy lifestyles to promote wellness all over the state. We have 15 department members. We have department members in 15 of the counties providing this education, and we collaborate on a daily basis with the stakeholders in the counties and also regionally and throughout the state to provide this work, and also here at Rutgers. We're always very happy to collaborate whenever the opportunity arises. So, for example, we work with schools in the counties. We work with early care sites. We do educate all age groups, but since we're specifically talking about children today, I'll mention schools, early care sites, agencies that assist children in a variety of ways. We also work with medical professionals. We work with, any agency you can think of, and collaboratives. An example would be, on a state level, would be the New Jersey Department of Health. Our department was recently given 4 counties to implement SNAP-Ed, and we've been doing that for a few months now, and are doing that with a great deal of vigor, and it's going fairly well. And we're looking forward to the coming 2 years, since it's all up and running now, to get that going. Michael was just mentioning the fresh fruit and vegetable program that will hopefully include SNAP-Ed, and may include some of the counties that we're working with. That's another collaboration that we work with. But we collaborate to implement not only direct education, but PSE changes in the counties that we are in. So. We are also, I know we wanted to talk about where we're going. Our department has changed over time in many different ways, but decreasing overweight and obesity in early childhood and in promoting wellness overall are our goals. And a few ways that we especially kind of have stayed the same throughout time are the basics. Teaching children about nutrition, food, where it comes from, garden-enhanced nutrition, for example, and promoting family meals. Family meals was mentioned several times this afternoon. I was delighted to hear that because the research shows, and we all have probably just an instinctual feeling that family meals are a good thing. So I'll put in there a positive family meal experience is definitely something that can make a difference, and our department is working on an initiative to promote that even more.
So good afternoon. I'm Al Talia. I'm a family physician with a background in public health, and I chair the department, you may have heard of this, Family Medicine Community Health at Rutgers Robert Wood Johnson Medical School. Before I just tell you a little bit about the clinical vehicles that might be an opportunity for research collaborations and some of the research that goes on in the department, I just want to thank Dave and Arnold for inviting me, because every time I come here and have a meal, my internal biome changes for at least 3 weeks. So it's going to be interesting over the next 3 weeks, and I think it'll be for the better. So our department at the medical school is about 60 plus faculty, and over 200 individuals who participate at some level within the department. We touch over about 100,000 patients during the course of a year in all kinds of settings, including inpatient settings as well as post-acute ambulatory sites, including 2 urban FQHCs, the Eric B. Chandler Health Center in New Brunswick, you may be familiar with, as well as the soon-to-be-opened Family Health Center in Freehold, as well as caring for folks in their homes through our home visit program. We care for over 3,000 elderly individuals per year there, in school systems, including the New Brunswick school system and many college systems, employers, and other locations. So we have a large clinical operation, a variety of different sites where people are, and particularly children, and I think that's an opportunity that we would be welcome to work with you in terms of collaborations. On a research side, we have a large research enterprise including individuals. It's based at the Institute for Health here at Rutgers, including individuals who are interested in obesity prevention. A lot of our research is basically how do you improve the quality of the healthcare system that is somewhat dysfunctional here in the United States, but we have a variety of different efforts that are targeting different layers, patients. We have projects that are targeting practices, primary care practices, and we have interventions that are targeting communities. So we have a lot of activities going on that would relate to the New Jersey Healthy Kids initiative. And again, we're looking for collaborations. Some of the laboratories that we use, we have a practice, actually the only agency for healthcare research and quality-based practice-based research network in the state. It's made up over 100 primary care practices, the New Jersey Primary Care Research Network, based in all 21 counties here in the state. We are about to sign a research and education affiliation with the VNA Health Group here in New Jersey. That is the nation's second largest VNA that touches more than 13,000 people daily, including kids, distributed throughout the state. So our laboratories, if you will, are in communities or in locations that you've all talked about today. The aspiration I have, I guess, coming from this today, and is that the New Jersey Healthy Kids Initiative will be able to build multiple research collaboratories, meaning linking the scientific community with populations based in different communities, organized in different family structures. There are multiple vehicles for collecting data, discovering relationships, designing interventions that we've heard about today, that I think our goal is to get to the right interventions for the right people at the right time, so that we can understand what works and what doesn't. So thank you for inviting me. Exciting to be here, and I look forward to working with many of you in the future.
Hello, good afternoon. I'm Wendy Neal. I'm an adolescent medicine specialist. I'm representing the Department of Pediatrics. I'm going to sort of shift a little bit, but in no means I believe in prevention. Prevention is the way to go. But within the Department of Pediatrics, we're putting together an initiative to address those kids who are already morbidly obese. And so we're putting together an obesity treatment program. It's a collaborative effort between the Department of Pediatrics and the adult GI specialists. And what we're doing is this program is going to focus on lifestyle changes. And so we don't call it, diet or things like that. We're looking to change behaviors over the lifetime, and hopefully changing those behaviors, helping to change those behaviors within the kids will spill over into the family as well. It's multidisciplinary. As I mentioned before, we have dietitians. We're going to have mental health specialists. We're going to have exercise experts, as well as the stage 4 of the program is working with the adult GI specialists for those patients who endorse going on to have a new procedure called endoscopic sleeve procedure, as opposed to having open bariatric surgery where there are scars. This procedure is the GI specialist will go down through endoscopically do the sewing of the stomach that way. Therefore, there's no external scars, which which may be more acceptable. We don't know yet. That's part of the research that we're going to look into. It may be more acceptable to the adolescent patient than the current sleeve procedure that we have available. The program is individualized, which makes it labor intensive, as one can imagine. But all the data, the research shows that these are the type of programs that you're going to have the most success with, is individualizing the program to the patient that's sitting in front of you. You have to be able to understand the social context in which this patient is living. And I cannot tell you the amount of stress and anxiety that I encounter in this population. And if you don't address these types of issues, there's no way you're going to have successful behavioral change. So I'm very, we set very minimal goals at each visit, no more than, I tell patients, we work with the patient and the family, and we say, tell me 1 or 2 goals that you want to work on. I won't accept any more than that because, like all of us, if you ever tried to make a behavioral change, and if you set out to do 50 things and you don't do, even if you succeed at one of them, you feel like a failure because you didn't succeed at the other 49. So the whole idea is to use motivational interviewing techniques and stages of change, meet patients where they are, and not set unrealistic expectations, and work with the individuals, closely monitoring them. I usually see these patients, depending on where I assess their stage of change is. There's some patients that come in and say, I don't want this, or I don't, my parents dragged me here. So then we work with that patient, and maybe we'll, see that patient every 2 to 3 months, as opposed to monthly, where the person is at the ready for action stage, where they're motivated, they're ready to go. Those patients we really monitor very closely monthly, to work on and praise them and keep set the next goal step once they achieve the first goal step. And these are behavioral models that are evidence-based and has been shown to be the most effective way to approach obesity. But like I said, the downside is, as you can imagine, takes time, takes a lot of different personnel to be successful in implementing these models. But as far as we've tried a lot of other things, and I think this has been the most successful published data. I also do the opposite end of the spectrum. I see patients with anorexia nervosa as well. And so the same concept of motivational interviewing, meeting people where they are and understanding their lifestyle and what's impacting their decision-making and their relationship with food is critical. And I think until we develop models that address those issues, it's going to be very difficult to address the obesity epidemic that we are encountering in this country.
Thank you all. I think you can see that we have, even here, just the tip of the iceberg of the real breadth in expertise, both research and outreach to the community at Rutgers in the areas of this conference. And in fact, as I listened to all this, I thought we should probably do a developmental dynamics study of everything that's available around Rutgers in order to know who's here and how we can really work best together. In that vein, though, listening to talks this morning or topics that we're interested in, I would do 2 things. I'm going to ask panel questions, but also open it up. So before I ask questions that we're coming from, does anyone have any questions now based on some of the thoughts and ideas that you've been hearing from our very esteemed group of Rutgers professors? Any areas that are of interest? Yes, please. That's exactly the reason we're sitting here. Does anyone, to see how we can begin to make all of these pieces fit together with the Healthy Kids Initiative. But I'd open to the panel to ask, are there particular areas based on what you've heard today in the talks, based on other sorts of areas of collaboration across Rutgers that you could see your work or work that you know of coming together around the Healthy Kids Initiative and around giving back to the community in particular?
Yeah, I mean, that was actually my aspirational comment about developing research collaboratories, because I mean, Rutgers is a research-intensive university, and there's a lot going on around the room, as you can hear. The question is, how do you link those? And the concept of collaboratories, I mean, I could just lean to the left here with my colleague from the Extension Division, right? I can think about 12 projects off the top of my head that would work based on what we are each currently doing in our different departments. So I think that was actually one of the motivating factors for this particular conference, is really to get the juices flowing and the collaborations operational.
From a clinical standpoint, seeing these patients in my clinic, I think we have to demystify the idea that healthy food is nasty food. And I think the Institute can really play a major role. And I think where that also comes from is really improving the taste quality of school lunches. Majority of the kids that we see or we work with eat most of their food at school. They're eating their breakfasts, they're eating their lunches. And so oftentimes they're skipping it because they say it doesn't taste good. So I think like the Institute could really maybe work on a state level. How do we improve the taste quality of healthy foods and implement that in the schools? Because the most obese kids are not obese because they're just sitting around gouging on food. It's because they're skipping meals, right? Or they're skipping breakfast, they're skipping lunch because it doesn't taste good in school. And then they get home and they're starving. And when you're starving, you don't make good choices, as we all can probably attest. And I'm guilty of that as well. When I have a hard day and I don't have time to eat lunch, what do? I do something very naughty and probably just pick up something on my way home, fast food on my way home, because I'm starving. And I need, your body craves it. So I think I really feel that that's an area that we need to work on, and also making affordable healthy foods. That's the other big issue. Anything that's healthy tends to be more expensive. And how do we combat the cheapness of the unhealthy food? And that's another, area that we need to address. And I think community gardens may be a fantastic way to sort of demystify the vegetable bad thing. And if communities get involved in growing their own food, et cetera, it would help to demystify the vegetables being the bad person.
I'll just add that our department, FCHS, is set up and ready to go. Our network is out in all of the counties. There's a cooperative extension office in 20 of the 21 counties. We are in 15 of them, but there's availability to have community interventions implemented in all of the counties, and we're ready to work with the New Jersey Healthy Kids Initiative to implement whatever comes down the road.
I think we'd like to collaborate with the Institute in trying to expand the cross-sector work as a result that can arise as a result of findings from all this work. I mean, we are committed to communicating to community groups and community coalitions what we have found to be effective, as I mentioned before, but also we're partnering with the intervention work we're doing. We don't want it to take a federal grant or an NIH grant to mount an intervention. So as Sherry mentioned, we're relying on and have the commitments from the SNAP-Ed programs who are committed to policy and environmental change to actually facilitate these partnerships between, in this case, and this is just an example, schools, the fruit and vegetable program, stores, to try to move this. We also do a lot of work with schools. We depend upon school nurses, the 120 and the 120 public schools that we follow in the 4 cities. And so I'd like to see an opportunity to try to expand this through perhaps the Institute's work, as well as through the work of of a lot of the coalitions. There's also the New Jersey Partnerships for Healthy Kids that Marissa and others have been involved with, as well as the initiative here.
I think the thing I would add is that there's an incredible amount of exciting research being talked about today, initiatives and interventions, some brilliant people in the room, some fantastic resources across Rutgers. What we haven't been good at is bringing that together effectively. The systems that we have for communicating, for building teams together, for understanding what resources we have across campus are poor, and we're particularly hampered by the communication between the health schools and the non-health schools in New Brunswick. Our new Vice Chancellor for Research and Innovation is working a bit in that area, and I think that's a very important step that we need to support. Being able to have a established, resilient network of communication of Associate Deans of Research, it's a kind of boring but essential part of building that up. We need some internal information systems that can allow us to join things together. And again, this isn't exciting to do, but it's really crucial, I think, in building work in this area, which is essentially joining across between sociologists, psychologists, communication, various kinds of biological and genomic sciences and so on. Without that, we are going to be hampered.
Other questions, please?
Hi. My name is Patricia O'Neill. I'm a school nurse at the Wandale Elementary School in the Saddle River. And just a couple of questions came to mind, Professor Yedidia, when you were talking about fresh fruits and vegetables. And some of my students have you heard of the oral allergy syndrome? So they're limited in what certain kinds of, I think they're called rock fruits, that fruits that have large pits. So they're not, able to consume those foods unless some of them are cooked and the proteins are changed. But that's just one thing. The other thing I want to say is your fresh fruit, is it organic or just fresh? Is it pesticides used, or I'm not really sure. And then the skin carotenoids you were talking about of the fruit, some children, if they consume the fruit, the skin of the fruit, that causes reactions. And I question, I wonder if it was organic or not.
I don't know whether the food in the fresh fruits and vegetables program is organic or not. I will say that when I was talking about the skin carotenoids, that's a non-invasive way to measure, the amount of fruit and vegetables that you ate. It looks suspiciously like giving a fingerprint, which is a problem, by the way. But somebody in the audience.
Well, SFVP is a competitive program. So it will, in schools that have, it's only up, the schools that are eligible to apply have to have at least 50% free and reduced. But because it's so competitive, generally speaking, you have to be 75, 80% or higher free and reduced in order to be selected. So it's not,
But I don't know, it's Department of Agriculture, so I don't think the food is organic, but that's what I think that was.
it depends, we can't say that it's not organic because it's up to the local school district of what they choose to purchase, but basically it's not a requirement that it's organic.
Most of the schools that I've worked with in the past, yes, they can purchase, but as you can imagine, the price point on an organic fruit or vegetable is not going to be what a school district as a food service manager can afford. So yes, it's a potential, I guess they can, but on the experiences I personally had over the past 19 years working at SNAP, it's just not an affordable purchase. And the types of fruit and vegetables or fruits that they're purchasing are not your exotic fruits. They're not purchasing lots of mangoes or lemon juice or starch. It really depends on how much money that particular school district has to spend on that formula. So it's not and then if it is, it's usually like a fruit a week. It's like one thing. It's not like a fruit salad that's coming in with like 5 fruits at a time. And then if that particular fruit, whatever, maybe 3 of the month, 3 of the week, and then you usually work with your nurses, and work with the health educators in the school to provide curriculum around that particular fruit or vegetable, and then work with the nurses in the event that there are particular allergies and how it's being incorporated. Is it an in-school, in-classroom thing that they're going to be tasting, or is it in the cafeteria? So it really depends on the school district, what the curriculum is, how they're going to disseminate it, what the guidelines are for the program. So it's not really we come all in and we'll just
I think many times it's not the whole district too, it's a school.
It's a
It could be a
school.
school.
It's
Yeah.
a school.
Yeah.
Because there is a percentage requirement. So not all schools have the same percentage of free and reduced lunch programs. And again, the percentage of the it's competitive to an extent because there's a finite amount of money that can be disseminated to provide for the program.
And the program that Dr. Yedidia is talking about, the fruits and vegetable program in the school will already be implemented. They'll have the guidelines to implement that program. That's not a part of what he's talking about doing.
You have a question?
Yeah, there's a lot of focus on fresh fruits and vegetables in farm markets. And is there any education for families to use canned alternatives or frozen that could be as nutritionally significant for them if they can't afford more fresh produce, especially families who might fall in the gap between being financially stable and getting some kind of subsidy?
Well, I can just speak for any programming that we provide, that we always encourage all forms of fruits and vegetables count. And it's a big part of what we teach. As far as the fresh fruit and vegetable program, though, I have a feeling it has to be fresh fruit and vegetables. At this point in time, it does.
They did research to see if they added canned, so like, for example, in Alaska and other places. So they did research pilots, and consumption went down.
So I'm going to change.
In the schools.
I'm going to change gears a little bit for the last couple minutes of this discussion in a topic that I think may well carry over into the more general discussion. Dean Potter mentioned just the difficulties in even communicating across Rutgers. But what we've heard as a theme over and over today is the critical importance of being really almost embedded in the community, of having a really very tight interaction with community for everything that we're trying to do in the long term. So I just wonder, does anyone on the panel have any thoughts about how to culture and enhance that? I know Dr. Yedidia has been working some in that area, and Dr. Potter is involved in communications. Each of you has a real community effort and impact, but it clearly is a critical aspect of success and where there are real barriers. So any thoughts that you might have across the panel around community interactions with New Jersey Healthy Kids Initiative?
Well, the one thing I'll say, Bob Atkins gave me a shout out earlier that was very sweet and all, felt welcomed about the evaluator, but I'm not. That's the point. I was tapped by RWJ to provide an evaluation, 20 communities focusing on 20 outcomes. I didn't take that on. Instead, though that's a valid sort of concern, I said I will go and based on what the communities have said they want to do and the measures that they've talked about of success, I will offer them to help measure those things. But I will offer it based on what they've said that they could use. I may go further to try to illustrate rather than say, so what do you want me to do, of what I could offer and how it might help them tailor and target their programs. But if they don't come to me or if they have other competing kinds of needs in their time, then that's fine too. And in fact, some of them don't because it's not within their priorities. So I think, that I can't say that's a model because programs, there's something to say about evaluating programs. And I've done a lot of program evaluation over my days. But I think maybe going out and illustrating how measuring things can be helpful to the mission of the group and how you can do that without a huge cost and an NIH grant, I think is providing some service. And I think that's something that we in academia can learn, first of all, from community organizations, what it is that might be helpful to measure, and then help with the technicalities of how to put together a measure.
Dr. Potter, did you have any thoughts? I don't.
The only thing I would add to that is that I think being able to work, joining together the food and health piece with other crucial issues that communities are concerned about can provide extra resources for those communities and extra buy-in. And again, for us, we're very concerned. You've probably been reading about the New Jersey Civic Media Consortia and the way in which local media is failing in New Jersey in different ways, and trying to get some money from the state, from their sell-off of broadband, to come back in to support local media. One of my interests is joining those kinds of projects together with other projects to do with health or with social care, so that you can make the absolute benefit stronger as these things add together, because some of the systemic support, some of the tech support is the same kind of thing.
Dr. Serrano? Sorry for butchering your name.
Just Sherry.
Sherry.
Is that still on? I will echo the idea of making sure that when you go into a community, you're providing something that they want, something that they will benefit from, and also would encourage when developing any kind of intervention or study that you're looking at what already exists, the networks there, the collaborative, the agencies who are already working together and know the community really well, that they can assist in many ways, helping to implement and maybe helping to find bodies to help implement. And but it's key to work with the people who are already on the ground.
What I would say, Arnold, is that for several years now, the Office of Community Health and the Division of Community Health within my department has taken the initiative to organize stakeholders in the New Brunswick community, and in fact in Middlesex County, for purposes of surveys on what exactly is important to the community from a health perspective. And that's published regularly. The problem, of course, is always funding for these kinds of studies and these kinds of collaboratives. But I'm happy to say now that the Internal Revenue Service has essentially provided a means to do that, in that all nonprofit community hospitals are required to actually provide community health services as part of their ability to remain nonprofits. So you heard it here. Go knock on the door of your community hospital in your area as a nonprofit with a good idea for improving the health of the community.
I'm just going to speak about a different community that we probably are not aware of. That's the medical school community. The doctors, our young doctors, have an important role to play, and we get very little nutrition education in medical school. And I believe that this is an area that we can make a great impact on, because if we start training our physicians who are going to be impacting patients, and if they're comfortable with this topic, they will be able to transfer that information onto their patients in whatever community they're working. And it is severely lacking in medical school training, nutrition education. And this is a place where I believe the Institute can have a major impact.
So our time, David?
Just one comment to follow up on Dr. Talia's comments. There was a report done by Healthcare Without Harm in 2017 that did a national survey of hospitals in their use of community benefit dollars to increase healthy food access. So if you have a chance to take a look at that, there's a lot of information and even examples of how we might advocate to our nonprofit hospitals that have a required community benefit responsibility. So take a look at that. I think there's a lot of work that we can do in that aspect, and there's a lot of money there to do a lot of things that aren't health care, yet still improve the health of the populations that are served by those hospitals and the populations that we serve as well.
Right, guys, one more question.
Actually, it's a comment, very short comment to Dr. New's suggestion on training, proper nutritional training on medical students. And here at this institute, we have a new center for nutrition, microbiome, and health. And we actually start to try to offer PhD, MD, double degree education. And we want to open the discussion with you guys and to offer this kind of opportunity to medical students.
I'm going to say, take the liberty as chair of the panel or discussion leader, to make one other point that struck me this morning as we were listening, is the issue of sustainability of the community interactions, which clearly is a problem. I've seen that not only in this field, but in other nonprofit volunteer sort of activities I've been involved in. And one thought, if you look at our medical school, there have been a couple of initiatives driven by students that have now been sustained over 20 to 30 years. The hip hop program and the Promise Clinic, which are both really on the ground and go year to year, and the culture is the medical students and the seniors teach the juniors and the incoming students. So there's sort of a continuity of it. And it really led me to think that for a number of the points that we're talking about, even the Rutgers undergraduates could be a really valuable link to some of the community organizations. These are very manpower intensive, woman power, person power intensive interactions that we're talking about, but the sustainability of it may be by establishing sort of specific programs with specific community partners that would be through undergrads from generation to generation being passed down, like the Promise Clinic. And the hip hop program in the medical school might be a way to really initiate and sustain some of these interactions as well.
And include breastfeeding in that nutrition as well for the medical students. We actually put a plug in.
Here at the Institute, we work with undergraduates. We call them IFNH student ambassadors. And you may have met some today when you registered, as they were involved in the registration process of the conference, but we also use them to lend the student voice to anything that we do here at the Institute. So we have right now, I think there's 9 student ambassadors from all different majors across the university to provide that undergraduate student voice to things that we do right here in the Institute.
Terrific. Well, I want to thank all of our panelists very much for a great discussion and turn it over to David to finish the program.